Very good evening, everyone. On behalf of IAP India technical team, I, Dr. Jaspreet, welcome you all. Firstly, I would like to welcome our today's guest of honor, Dr. Sthiti ma'am, and our today's speaker is Dr. Kazi Arafat Basir sir, and our today's moderator is Dr. Kaushik Malik sir. Before over to Kaushik sir, I request all the participants please like and subscribe IAP India YouTube channel and Facebook page. Over to you, Kaushik sir. Please moderate this session. Thank you.
Thank you, ma'am. I, Kaushik Malik, Vice President of IP West Bengal. Good evening, everyone, and very warm welcome to all of you on our 9th webinar on cerebral palsy, early intervention and identification and intervention by Kazi Arafat Basir. Now, I would like to introduce our organizer, President Dr. Kaushik De. Kaushik De, please say something.
Unmute yourself.
Unmute, please. Unmute, please.
Sorry. Good evening, all. I welcome Dr. Kazi Arafat Basir. He is an eminent pediatric physiotherapist and he is also my hospital colleague. I welcome him and also I am thankful on behalf of our West Bengal branch. I welcome our Honorable National President, Professor Sanjeev Jha sir. I welcome Dr. Siti Progan, Madam, President of Odisha branch, and I welcome Dr. Risiraj, CEC East, and I welcome all viewers today. I express my thanks to Dr. Kaushik Malik, our Vice President. I express my thanks to IAP technical team. I welcome all the IC members of West Bengal. I am thankful to Dr. Kazi Arafat Basir again, and I wish all the best. Thank you very much.
Thank you, Kaushik. And now I would like to call Dr. Arindam Seth, our State Secretary. Arindam Seth, please say something.
Good evening, all. It's the 9th webinar organized by the IAP West Bengal branch and Women Cell. I express my thanks to Siti Pragyan Madam to give the time to present with us and boost up for our doing better for the professions. I cordially welcome our beloved physiotherapist, Kazi Arafat Basir. He is one of the eminent pediatric physiotherapists in West Bengal. Welcome, Arafat sir. And I express my thanks to the Kaushik Malik sir. He is doing all the great jobs to organizing this webinar. I'm thankful to the IAP technical team giving a nice support. And last not the least, that the Ruchi Vasnai madam and our National President Sanjeev Jha sir and CEC East Zone Rishi Raj for giving us moral support to doing the better for this professions. Thank you.
Thank you, Arindam. Now I would like to call our guest of honor, Dr. Sriti Pragyan Dalbera ma'am. Presently, he is a HOD, Institute of Medical Science and some hospital. She done MPT in sports from NTR University, Vijayawada in 2010. She also worked SB Nitra College and so many. Ma'am, please say something.
Thank you, Kaushik. And it's a lovely evening for this elaborate introduction. It's an honor to be the guest in the webinar of my neighboring state of West Bengal. It's a really innovative gesture of including the state president as a guest. I'm humbled to be sharing the same screen space with Dr. Kaushik, with Dr. Arindam, with Dr. Jana, and of course, Tanushri from the Women's Cell. And I just did a little homework regarding the resource person, Dr. Basir Arafat sir. you seem to have a very good working experience, starting from the Indian Institute of Cerebral Palsy to AMRI Women and Children's Hospital to Kisholoi Children's Hospital. It is a tough job to screen the neonates and then interpret the findings of their behavioral disorganization. And in one of the Facebook also, I came to a proverb where he has written that a disease may be rare, but hope should not be. So Dr. Basir, you are the hope for all the CP kids and also a hope for the parents of those CP kids. Thank you. And since I'm on air for the first time after WCPT, let me thank our national head, Dr. Sanjeev Jha, and all the central CEC from like a phoenix, we have risen from the ashes. I mean, coming back to WCPT is really a great honor, and it feels very nice. So I thought, let me take this platform to thank the Central IEP-CEC. Thank you, and thank you, Kaushik, for having me here.
Thank you, ma'am. Thank you. Now I would like to call our Joint Secretary, Subhendu Jana. Subhendu Jana, please say something and introduce our today's speaker, Dr. Arafat Basir, sir. Subhendu Jana, please.
First, thank you to all. Am I audible?
Yes, yes.
Good evening to all. After we are entered in WCPT again, thanks to our national team, Arafat is a very good child physiotherapist. The pediatric physiotherapists like Arafat, they done a good job with the children. Arafat Basir, a pediatric physiotherapist with more than 15 years of experience on doing his job. His primary area of focus is on children with sensory processing issue and motor impairments. Skill enhancement, writing, eating, socializing, play, and self-care skill too. He completed Master of Physiotherapy from Chaudhary Charan Singh University, Meerut, and he completed his DPT from IPCMER, Calcutta. He trained in NDT Bobat. He also certified in advanced mentor children for sensory processing. Level 2 AMT practitioner is also trained in methodology in music therapy, certified in excessive art therapy, trained in basic advanced placed method on the quantitative assessment of general movement, trained in Hammersmith infant neurological examination also. He was attached with Indian Institute of Cerebral Palsy (IICP), High Risk Newborn Follow-up Clinic, Department of Neurology, SSKM Hospital. He was done extensive hands-on training from CMC Velo and Kasturba Medical College, Manipal University too. A very good child physiotherapist. Thank you, Basir, to do this webinar for us. Thank you. Over to you also.
Thank you, Subhendu. Thank you. Arafat, Dr. Arafat Basir, sir, please continue your today's session.
Thank you very much, Shubhendu, for nice introductions. And I would also like to thank Dr. Srititi Madam from from Odisha, and you were with us. So thank you very much. And I would like to thank Dr. Kaushik De. He is one of my senior colleague at my hospital at AMRI Mukundapur. I do my pediatric work, and they are looking after the adults with others neurologicals and orthopedic disorders. I do thank Dr. Arindam Sheth and Dr. Kaushik Mullik, today's moderator, and and especially for the invitations for today's webinar. I express my sincere thanks and gratitude to IIP India, our President Dr. Sanjeev Jha. I would like to thank IIP India Women's Cell, IIP West Bengal branch, and as well as IIP technical team. Now I am going to start my lecture. Can I share the screen right now? I'm going to share the
Yes, sir.
screen. Yeah, thank you. Yeah. Yeah. Today's my topic is cerebral palsy, early identifications and interventions. That we are familiar about the terminology of cerebral palsy, everyone knows, but if we think about the early identifications, then we can plan the interventions very early. The early identifications is always better for any sort of medical disorders. Then we can intervene very early and we will expect a very positive result from the very beginning. So that's why today's webinar is designed for early identification and interventions. And structures of today's webinar is, first of all, I do like to share a few of terminology of cerebral palsy. Today we all of know about cerebral palsy, the definitions, the classification, but just an overview or recapitulation, we'll go through that. After that, the very important is we'll discuss about that early identification tools. Today, I am going to discuss two internationally standard tools by, and these are the tools is most commonly used by the developmental professionals nowadays with a very good outcome measures. And definitely after that we'll discuss about the management approaches, we'll summarize our session, and definitely I would like to be attend your questions. You please put all the questions in that chat box, and we will definitely try to sort out with our time. The definitions of cerebral palsy, the definition that search for internationally accepted cerebral palsy for all professionals is still on, but still we can take these descriptions as a standard descriptions. I would like to just read these descriptions of definitions. Cerebral palsy describe a group of permanent disorders of development of movement and posture causing activity limitations that are attributed to non-progressive disturbance that occurring in the developing fetal or infant brain. The motor disorders CP are often accompanied by disturbance of sensation, perception, cognition, communication, behavior, epilepsy, and by secondary musculoskeletal problems. If anyone is asked me that please define cerebral palsy like 1, 2, 3, then I would like to cerebral palsy like 1. It is a disorder of movement and posture. Cerebral palsy is a disorder of movement and posture, number 1. Number 2 is it is occur due to a static or non-progressive brain damage of premature brain during prenatal, perinatal, and postnatal period. It is also associated with visual impairment, hearing, cognition, behavior, and communication, and sometimes seizure disorders is also same with children with cerebral palsy. So this is the basic definitions. If you ask me, that there is a 3 component, and as cerebral palsy, it is a disorder of movement and posture, and we physiotherapists are the expert in movement and posture, so we play a key role for the management of cerebral palsy among with that other fellow professionals. So I would like to share some few picture of children with cerebral palsy, And just take a look about this picture. In this picture, we found that there is a children with increased tone in the whole body. In this picture, the picture is shows that the baby with persisting ATNR, asymmetrical posture, the fisted hand. So we can assume that the baby may be quadriplegic along with hypertonic posture. Along with, if you go to the downwards, these two picture, if this picture, we found that the baby's whole posture is C-shaped and it is totally flexion posture. The head are flexed, the trunk are rounded, arm are loosely placed, and leg are abducted, externally rotated. So this is a typical posture of flaccid type of cerebral palsy. Look at this picture. Here it is also the persisting ATNR. The posture is totally, means the baby is placed in not conforming his posture. The baby is not maintaining the supine line. The posture is total C-shaped or total extension pattern, or it's called the opistotonic posture. And along with that, the baby continuously moving like a dystonic child. Yeah. Here also the same picture is happening. And in this picture, this is a very interesting another picture where we have found that when the baby is placed in a ventral suspension positions, the baby is trying to fly. Here, this is not a head control. This is basically extensions of that head. And along with, there is an increased tone on both the arms. And another this picture, there is a baby with increased tone on his left side of the body. The baby is holding a biscuit, and with the increased tone, he is anchoring and taking support from the floor. So this is another interesting picture. In this picture, this is also an interesting picture. Here we found that the baby has an increased tone in the left side of the body with a right side facial palsy. And same, this is a children with right-sided hemiparesis. This is a children where there is a titubations of the head or nodding movement, continuous nodding movement of the head. Then a hand is moving. So maybe, yeah, this is an ataxic type of cerebral palsy. Here also we can found that that the children is bearing weights on more on his left side of body than the right side, and that he is his leg, the toe is raised, and the TA is also tight. So this is children with hemiplegia or hemiparesis. This is also a picture of children with diplegia. Here the baby is that the tone is increased in both the lower limbs. He is holding a toy on his both arm, and to manage to holding this toy, there is a flexions of hip. Both the hips are adducted and internally rotated, and knee is semi-flexed to manage and maintain the posture. So there is a picture of children with diplegia. And here also there is a picture of diplegia. The baby is increasing both the lower limb tone to maintain upright posture. So I am showing few pictures to describe different type of cerebral palsy. If we think about the postural tone, if you take this is the blue line is normal, then if you think it is a spastic type cerebral palsy, the postural tone will be always increased from the normal. It is the spastic type of cerebral palsy, and in case of the flaccid type cerebral palsy, the postural tone always below the normal line. And for the dystonic type cerebral palsy, the postural tone may be fluctuating. Often it is increased by above the normal, and for the next time it may be decreased below that normal tone, or it is called underlying hypotonicity. So by zigzag format, that there is a presentation of tone is found. So I can put graphically like this way to describe the postural tone. And what is the component of cerebral palsy classifications that I already mentioned? It may be spastic or hypertonia, it's maybe flaccid or hypotonia, it's maybe athertoid or dystonic, ataxic or mixed type of cerebral palsy. According to the distributions of the postural tone, we may classify cerebral palsy when the, excuse me, when the four limbs are affected, then it is called diplegia. When the both the lower limbs is more affected than upper limb, it is the previously when the four limb is affected, it is called quadriplegia. When the both the lower limbs is more involved than the upper limb, it is called diplegia. And when one side of the body is more affected, then it is called hemiplegia. We often found the children with bilateral hemiplegia when one side is more affected than another side. So that is called bilateral hemiplegia. We also often found children with bilateral hemiplegia. And another important classification is according to the motor ability. And I would like to request you all, especially those are the students and those are interested in practicing in pediatrics, please do more attentions on GMFCS or gross motor functional classification system. It is internationally accepted for every professional, and to assume that the functional ability of a particular children. And how we describe the GMFCS, here I am showing you the picture or format of GMFCS scale. There is a level, level 5 is there. It is 1, 2, 3, 4, 5. When there is the level 1, that the child is able to walk without any limitations. And if we think about level 5, the child is dependent and it is transported by manual wheelchair. Means the one is less severe one, and we think about level 5, it is the most severe one. Now the trick says 1, 2, 3 and 4. What about level 1 limitations and what about level 2 limitations? Level 1, the child can able to walk, able to run, able to jump. They have few issues on coordinations. And in case of children with level 2, they also can walk. They also, but there is a difficulty in climbing stairs. In level 1, they can climb stairs without holding support, but in case of level 2, they need support. They have a difficulty to overcome crowded places. They have an issue to overcome that spots, holes, or uneven surfaces. So this is comes under level 2. And if you discuss about level 3, the baby is able to maintain mobility with a handheld mobility device. It's maybe crutches, maybe walker, or maybe wheelchair. And functionally, they are also able to move. But for long distance, travel to long distance means if you ask that children please come to GMFC's grade 3, if you ask from one airport to one corner to another corner, maybe they need some extra support with wheelchair. Okay, and GMFCS level 4 is it is self mobility with limitations, maybe use power mobility. They are able to move, but there is lots of limitations. Means their energy is easily they are lost their energy. They can't able to walk more. If you ask the baby to move from means walk for long distance, there they feel more difficulties. And the tricks between level 3 and level 4 is level 3 have a very good trunk control. That's why they can easily move to one place to another, and That level 4, there is a lesser trunk control. That's why they are prognostic outcome is also not good. So this is the GMFCS grade 4. Why I am describing it right now, and I will discuss this later from other tools. Expected prevalence of cerebral palsy in India. Current prevalence of cerebral palsy is India is 3.5 to 4 per 1,000 live birth. True prevalence of is preferably higher due to underreported. We know that we Indians are not maintaining our data properly. That's why many of the children is underreported. Improvements of neonatal care and reductions of neonatal mortality rate, lack of universal evidence-based antenatal, neonatal and infant care, increased survival of high-risk cases, lack of awareness regarding early detection and intervention among the healthcare professionals, lack of effective early intervention strategies, and burden of finance to the family, and lack of financial support from government in CP management. And what are the risk factors of cerebral palsy? It is just I'm go through it. That definitely the birth asphyxia plays the key role of cerebral palsy. Nearly 44% babies are found with birth asphyxia, and low birth weight 33% babies, and preterm is 90% babies or preterms are found with cerebral palsy. And if we risk factor according to the gestational age, if the baby is below 31st week, they are delivered below 31st week, then the chances of cerebral palsy is more high than the baby is delivered to 37 to 38 weeks. And if the baby is born with a weight of 3 kgs and more than 3 kgs, there is a chance of cerebral palsy is very less, rather than his baby is born with 1 kg of body weight or lesser than. CP prevalence is definitely improving with better neonatal care. You see the graph was hike on the middle of 1995, but generally it is reducing because of that intact survival strategies. Means that neonatologists or that healthcare professionals, all the team members, they are believe on intact survival strategies. They are not saving their life, but they are still thinking about their futures also. So that's why intact survival strategies is very important. There is a better ventilations and perfusions machineries is there, better infection and nutritional protocol, preventions of brain injury. That's why that improving in prevalence of CP is lesser in higher neonatal care or neonatal centers. Early detection and interventions for babies at high risk for developing cerebral palsy. Yes, I'm telling for this that early, if we do detect early and we intervene, then there will be lesser chance of cerebral palsy. And now I'm going to discuss about general movements or GM. It is developed by Heinz Prechtel. And please listen that the GM or the GM assessment scale can detect cerebral palsy with 98% accuracy. I'm telling you, 98% accuracy in the first few months of their life. Means within 4 months of their life, means after term age or 40 weeks of their life, that by GM scale, we can assume that the baby is going to be a cerebral palsy child or not. Is it amazing scale? And what is basically I'm going to describe that what is GM. A specific pattern of movement present in 9 weeks of fetal till 3 to 4 months after 4 weeks of age. uh, when the baby is on fetus, by 9 weeks they are start moving, and that the movement is come from CPR, central pattern generator, from brainstem or the spine. Basically, these all are the primitive movements. It is happening on the fetus, and the mothers are feels that movement from um, from 18 to 20 weeks of post-menstrual age. They feel that the baby is moving in fetus, and the same movements is continue up to 3 to 4 months of their life. And I'm telling you, I had experience, says, and I had asked few mothers. They're telling that we are feeling when we are taking the baby in my lab, we are feeling the same movements of fetus when the baby is on old. So this primitive movements, it is present from 9 weeks uh, of post-menstrual age to 3 to 4 months after term age. And after that, that particular movements or that primitive movement is transformed to that anti-gravity movement or intentional movement when the higher function is take part and the where function higher function is act. And by this assessment protocol, if we take that assessment serial longitudinal assessment, then we can get a better predictions about the baby is developing cerebral palsy or not. Single assessment at that age of 3 to 4 months give a better predictions. Normal age appropriate GMs is, if we found that GM is normal, 95% of chance of baby is not landed up to GMFCS grade 3 to grade 5. And if we found the GM is abnormal, 98% chance of baby is land up to GMFCS grade 3 to grade 5. I'm discussed previously about the GMFCS scale, and so I'm not going to repeat this again. Now, you please see the movements, the beauty of a movements of this baby. This is a baby of 44 weeks, means 1 month of age after birth, after 40 weeks. And you see that the baby is, there is lots of variety of sequences there. Sometimes their head is moving through a axis. 1 second, I'm playing the video again. You see there is a lots of movement. Sometimes the arms is moving, sometimes the leg is moving, sometimes the body is moving. There is a beautiful sequence is there, and beautiful complexity is there. And uh, if you find that the baby's posture is sometimes is asymmetrical, sometimes is come back to the normal. So this is a beauty of the primitive movements, and it is definitely it is purposeless movements, but this all are the primitive movements, and this is the beauty of primitive movements. And this primitive movements, when the baby is become older or 3 to 4 months, and this movements is disappear, and the new intentional movements is comes with these babies. Now I'm showing I'm telling it is a abnormal GMs, but it is cramp synchronized. Okay, if you saw this previous video, you saw there is a lack of variability, that there is a no body movement. The baby is maintaining basically asymmetrical posture. The sometimes his leg moving, sometimes his hand moving, but there is no sequences there, or there is a no movemental wave. So that's why we called the previous baby is a normal GM, and for this baby we called it's a cramp synchronized GM. You see both those two pictures. They are also the baby with cramp synchronized. They are a very lesser variant of movement. They all are in initio, and they are putting they are maintaining a fixed posture. They are not moving to other else. They are not, the movement is not at all classical, or there is not such variabilities there. There's basically the on and off type of movement is there. So that's why it is called cramp synchronized GM, or you may say abnormal GM. And how we put the GM in a score set. And for the assessment of GM, first of all, you need to certify for GM assessment. After that, you no need to take any other thing. You have only take the score set, and you need to have a better clinical eye. Otherwise, you for your future assessment, you take the video with your smartphone. That is so simple and so easy. And by this presentations, I am showing you that the movement is start from 9 weeks post-menstrual age up to 60 week of post-menstrual age. And here there is a two type of GM. One is normal and another one is so-called abnormal, but we don't say abnormal, we say pure repeater, cramp synchronized or chaotic type of movement. And how we use the longitudinal assessment? If we assess a baby at the age of 35 weeks, if we found that the baby at 35 weeks is playing, that we found the GM is classical and GM is fantastic, then we put normal at the age of 35. And after 2 weeks, at the age of 37 week, we do the same assessment. And if we found it is again normal, then we are also very happy. And if we found that at the age of 2 months or 8 weeks of postpartum age, and we found that baby has a very good GM or very good fidgety movement, then we must think that the baby will be a super boy or super girl. And if we find that the baby is under at the age of 35 weeks, which by time he born, doesn't matter. Means the baby can born is 27 weeks, baby can born is 32 weeks, because the GM is not means the movement is not affected in by means if there is a abnormal GMs, it is shows the abnormal GMs is there. And if the baby is born in 35 weeks and we found the baby is under pure repeater, or there is a lesser chance of, means the less variant of abnormality is there. And at the assessment of 37 week, if the baby is developing CS, means the problem is more worsened. And if we found another after 2 weeks, the baby is again developing CS, then we can say that the baby, there may be a higher risk or higher chance to develop cerebral palsy in future. So we put the baby in a very strong early intervention protocols. And in case we don't have time and we have found the baby at the age of near about 2 months to 4 months, and we found that the baby has a very good fidgety movements or very good GM, then we can think that baby will have a better outcome in future. And if you found in a single assessment the baby haven't shows that classical movement, then we think that the maybe it is abnormal outcome may comes out in future. So this is that all about the GM assessment. This is the GM score set. This is the, and now general movements is assessed through motion sensors. There is app is also available. You put that camera over the baby, and that the camera is detect that when the GM is start and when the GM is means how much classical GM is So that is detected by the machine nowadays. So it is amazing thing. And another important assessment toolkit is Hammersmith Infant Neurological Examinations, and how it predict cerebral palsy in very early stage of the life. Hammersmith assessment is done at the age of 3 to 2 years of the age. Means when we put the baby, when we find the baby has a difficulty or not a difficulty, but we can follow up the babies with a scale of Hammersmith. And Hammersmith is basically assessment protocols for the assessment of cranial nerves, posture, movement, tool, reflexes, motor milestone, and behavior. There is 26 component and total score of 78. The maximum per component, the maximum score is 3 and the lesser score is 0. And if we found that a baby is scoring lesser than 40, means out of 78, the chance of GMFCS level 3 and level 5 is very high. And if the baby is scored 40 to 60 out of 78, there is a chance of GMFCS level 1 or level 2, and the optimum is near about 73 to 74 out of 78. If the baby is scoring 73 and 74 out of 78, then we must say that the baby is a super boy or super girl. And this is that Hammersmith infant neurological assessment scale. And by this scale, we do assess the cranial nerve, we do assess the posture, we do assess the movements. I'm not going details in it. If anyone is interested or to learn more, they can contact me through email or through chat box, whatever possible. And this is the assessment of tone, assessment of reflex and reactions, and these are that for the scoring, and this is non-scoring part, and we have find asymmetry by this, and also the behaviors of the baby. And that kids is also we are using very lesser kit for the assessment of Hammersmith. We need only the proforma, this proforma. We need visual target. We need a basic rattles, few toys, and one tender hammer. That's all. That's all to do that Hammersmith assessment. And prediction ability of early detection tools. And definitely the GM assessment tools is that predictions of 98% to detect cerebral palsy in the very early stage of the life. And instead of, if we do not do the GM, if you do the MRI, the prediction ability is 86% to 100%. It is near about, if we mean it, mean percentile will be near about 89 to 97 percentile. And if we do cranial ultrasound for that infant, it's the prediction ability is near about 74%. And if you do a Hinge or Hammersmith neurological assessment, then the prediction ability is 88%. So by that two assessment toolkits with GM, general movements, and along with Hammersmith or Hinge, we can predict the cerebral palsy in very early stage of the life. So that we know that every baby is precious to us, and when the baby or very low birth weight or the preterm baby along with some medical other issues are there, that survival is the main concern. But definitely we are the professionals, those who are thinking about their life, their future, and our hope is totally depends on neuroplasticity. And what is neuroplasticity? Just continuous generations of new neurons in certain brain regions. New skill and experiences create new neural connections. Repetitions and practice strengthen neural connections. Connections in the brain that aren't used become weak. Though this is the basic about neuroplasticity, this is not the platform. I'm not go more details on neuroplasticity. And now I would like to discuss about that summary. Sorry. And basically it is my lockdown story. And one baby, a date of birth of 1st of November 2019, baby girl from Murshidabad. That mode of delivery is normal vaginal delivery, gravida 1, extreme preterm 27 weeker, extreme low birth weight 1980 grams. The baby was, along with RDS, respiratory distress syndrome. Surfactant was introduced on that time. The baby was ventilated. There was 2-time incident of sepsis infections. There was neonatal jaundice. Brain MRI shows there is a PVL, and total NICU stay is 70 days. And this is definitely not from my hospital. This is from another hospital, and baby came to me for assessment or for early identifications. I saw the baby as 47 week of his post-menstrual age, or and when the baby came for first time, I do the GM, and baby came from Murshidabad in that first week of March in this year, and we found that the baby had some issue in GM. The movement is not so good. There is a lack of variability. So I gave some sort of therapeutic plans, and then they went back to Murshidabad. On the 50th week, when they are in Murshidabad and all the Indias are locked on that time, and I asked the mother to take the video and send it to me for the GM assessment. And mother saying that the baby is become more worsen, that the movements quality is very poor, and they are definitely very much worried about on that time at the age of 50 weeks or that late or the last week of March video. Again, after 2 weeks, at the month of April, they send me another video of the baby. I do assess the GM. We found the baby is developing cramp synchronized movement. And the late April, they sent me again video, and we found there is a definitely cramp synchronized movement is there, that GM is absent. So, and the mother is also very much concerned about her baby, and the family also. They cannot, means the baby is very precious, 27 weeker baby. They had suffered a lot. The baby had suffered a lot. So that's why they don't want to take any risk. They came back to Kolkata when the unlock phase is started. And we do start therapy from early of the month of June, and after 2-month therapy, we do more work on head control. We do work on midline orientations. We facilitate the active movements. So after 2 months, the baby again went back to Murshidabad for a few days of leaves, and definitely that session is restricted due to lockdowns. Now the baby is developed a better head control with 2 months of therapy. the expression is changed, the baby is smiling, the baby is maintained sitting when placed, and now the baby is more comfortable than the previous video. I do the Heinz code or Hammersmith code. The Hammersmith code is 52. Just last week I did the score 52. The baby is now 9 months of old, and the CGA or corrected gestational age is 6 months of baby, and Hammersmith score is 52 out of 78. That baby is definitely in a borderline, but still we have a hope. If we left the baby in that cramp synchronized movement, if we don't intervene on that time, then the score may be below 40, or maybe very less score will be there. But after the 2 months of therapy, the parent and the family, they are doing an excellent job with the kids. They give more time to their kids. They are follow all those instructions, and see there is outcome, and hope, and definitely therapy is still on, and hope the baby will cope up with others. And this is another picture presentations where the and I will show the video of this baby also. Here the baby is not able to maintain the posture in supine line. There is opistotonic posture, so we put in a nest in NICU. The baby has some other issue also. There was a multiple surgery in his stomach, and some other issue also. The baby is developed tone all the time. So at NICU, we do early positioning for this baby, and gradually we maintain that midline positions, better nesting positioning. After a 9 month, when the baby was 9 months, the baby is developed very good head control. Definitely, there is an issue of setting. He needs some support to sit, but from this picture to that picture, I found there is lots of changes there. So if you discuss about that intervention, 1 second, sorry. So if we think about that interventions part of management of children with cerebral palsy is very early stage, that we need to think holistically. We are the expert in movement and posture. We previously said that we can prove through, we have proved our therapy by neuroplasticity. We have a strong methodology like NDT or neurodevelopmental therapy or Bobath concept. By the Bobath concept, Bobath is always saying that put the baby is reflex inhibiting postures. Here we are doing same with the help of hammock. In this pictures, the baby is have a opistotonic posture or total C-separate posture or total extensions of the body. Now the baby is putting in a hammock. It is basically a bed sit. It is available nearby that baby, and we put the baby in a hammock and see the eye contact from this picture to that picture. The eye contact is developed, both the shoulders come into midline, and if we maintain this posture, we'll definitely find a good result, and we'll give a positive response to the brain, or positive cortical representation to the brain. Here also this baby is total extension posture. We put the baby in a hammock regular wise and with other therapy protocol also, and we had found a very good result. Active facilitations is also very important for the management of children with of any sort of neuromotor difficulties. It's maybe with toy, it's maybe communications with the baby. It's maybe facilitations of extension overhead activity, rotations of the trunk, and encourage play more and more. Mother's involvement is very important in case of the baby was at NICU or not, and along with NICU positioning or proper positioning is very important. Active facilitations and relaxations and encourage for normal movements, that's all are very important, and this by this we can give more and more positive cortical representation or positive neuroplasticity enhance. We do gentle oscillatory movement through um, uh, through peanut ball, through digger. We do lots of cross hand activities or truncal rotations or extensions of the trunk, active extensions of the trunk. We do lots of vestibular activities and muscle core strengthening activities. And here also we are doing coordinations. Here also coordinations, maintaining posture, extension, active extensions, balancing. So by this different type of therapy protocols, if we provide to the babies, and definitely if there was a history of NICU stay or the baby was in a very high risk factor, but we will find a very good result. So to the conclusions of my topic is abnormal sensory experience of movements can be modified easily before abnormal posture and patterns of movement set in. Massive myelinations and synaptic connections occur abundantly during the first 2-3 years of life, and those may be fully utilized to form correct pattern of movement instead of abnormal one. Through handling and caregiving, correct posture can be maintained and variety of movement pattern can be encouraged. This ensure carryover of treatment, which is quite essential for plastic adaptations to inhibitions, abnormal tone and patterns of movements, and therefore more normal sensory motor experiences. Normal posture and movement mutually strengthen development of other systems such as vision, hearing, cognitions, which is immensely influence the cognitive development and early learning reciprocally. So thank you very much for your patience listening to me, and I would like to share a small video of a few of my guest child, those who are experiences their first steps after early interventions. Thank you very much for your patience listening. I am welcome. I think now it is 10 9 past 10 p.m. and we have a time of near about 10 minutes. I think Kaushik, we have a time of 10 minutes. We
Yes,
can
yes, yes.
and we can welcome few questions. If you have, please ask, and then I will try to definitely answer all those questions.
Participant, please put your question in the chat box. Actually, everyone are listening minutely, so they are, I think they are not get any time to put any questions.
I found one question.
Okay.
Jayashree Rai, and she asked that, can you please tell me some exercise for back control? And another, I'm finding some question, then I will try to definitely answer it.
Arafat sir, please, you can continue the answering. Participant will post their questions.
Yeah, yeah. So it is a definitely thank you for your question, and basically, yeah, that first, when the baby is born and the baby when the baby is their early stage of their life, they have their some primitive movements, and they then gradually it moves to the intentional movements. They develop intentionally head control, they develop intentionally the truncal control, rather than telling it's back control. I think truncal control maybe your questions. So when first of all, that we must think about the writing, means when you we can recognize our body, we are recognize our body when anyone asks me for any object or anything. If you call me from behind, then we are not moving our whole body, we just move our head and try to answer them. If anyone is pulling us, then our body is right accordingly. So we can separate our body, and this type of movement is start very early stage of the life. When the baby was 3 to 4 months, the intentional movements of head control is developed. When the baby is passing 4.5 and 5 months, then the extensions of trunk is happening, more extension of trunk is happening. If the baby is not achieve the more extension of trunk or more steadiness of trunk, then we definitely find out the baby is developed the head control or not. If the baby is not develop head control, please do work on head control, please do more work on midline orientation, put the baby in more prone positions. You can ask the mother or any family member, put the baby on his chest. When the parent is lying on a supine, place the baby on his chest and try to communicate with your baby. This is the basic tools or basic playing idea, and do communicate with your baby, and then gradually the baby will try to lift his head up. And when the baby is developed head up or head control, after that you can think about more and more of trunk control. By trunk control, you can give him the exercise of rolling. After that, you can give that more extensions, you can work on that extended arm support activities. After that, you can putting weight on that both that arms ipsilaterally, and also give some bouncing activities of the trunk. Then I think after head control, then you can easily achieve that truncal control. Thank you very much.
Thank you. Next question is, in some children, why we not seen the ATNR, STNR, but he is suffering from CP?
I'm not getting a question. Can you tell me again, please?
In some children, why we not seen the ATNR, STNR, but he is suffering from CP?
Acha. And ATNR and STNR, those all are primitive movements. It's may be present or may not be present. It is not always that ATNR, it is a brainstem level of reflexes by which that baby is not able to put both the hand in midline. But it's maybe or may not be present means clinically, but definitely they found that there was a tone or they may be flaccidity. It's often happening. It means if it is not seen in every cerebral palsy child, it is not every time it is correct to that you must seen that ANR to every cerebral palsy child. If, and HTNR is very rarely sent to children with cerebral palsy. Those cerebral palsy child is very severe because when the put the native in flexion positions, there is a flexions of upper limb and extension of lower limb. That is the STNR. Those are the BB is very dystonic and there is a total fluctuating movement, underlying hypotonic trunk. Then if you do the passive flexions of the head, then the flexions of upper limb and as well as extension of lower is happening. But it is also HTNR is also very rare for children with cerebral palsy. It is very rare, but ATNR is commonly found, but not always found in children with cerebral palsy.
Thank you. Next question
Thank
is,
you.
can you please advise exercise for improving eye coordination?
Yeah, definitely. That definitely that eye-hand coordinations is a very important tools or very important activity for any individuals. Means we are not means distally we are not able to work perfectly. If you when we are writing something, yeah, when we are doing any soft skill, we need to put the object in midline in front of our eyes. So the question is very important and I am trying to answer it. So the, the put the baby in, you can put the baby in prone line that I previously said. If the baby is very tiny or very small, then you can put the baby in prone positions over your chest or over mama's chest, and you can ask, and mama will place a pillow behind her, and she can directly talk in front of maintaining eye contact with the babies. So that is a beautiful idea with that eye contact. Otherwise, when you can place the baby uh, means on the mother's lap, and mothers can lean forwards with the babies and they can talk, they can play, they can give a rattle in different directions, so they can improve eye contact very early stage of the life. So these are the few techniques to develop more and more eye contact. Thank you.
Thank you. Next question, how to deal with spastic CP child? What is the accurate intervention to reduce spasticity?
Yeah. Uh, Definitely, if you treat children holistically, means you need to treat the children holistically. You no need to means that we are the pediatric physiotherapists. We don't do only the exercise. Listen to me. We are not doing only the exercise. Basically, rather we try to play with the child. Yeah. So you need to create more opportunity or more facilitated activity for the babies. How you perform, you try to facilitate, or you can give some oscillatory movement to the leg, to the girdle, so the baby may reduce their tone. After when the baby is gradually reducing their tone, put the baby maintain in uh, that particular posture, and you try to encourage him for active facilitative activities. Like if you put the baby in a peanut ball, you do a gentle oscillatory movement, the baby feel very comfortable, the adductor tone are reduced. After that, you can put a ball away from their body and ask him to reach out for the ball. Then the adductor tone are released, the baby's trunk is more active, and he also play or enjoy to playing with the ball. And along with that ball, you can tell this is a ball. You along with the therapy, you can educate the child. You can tell this is a small ball, this is a big ball. You can tell that this is which color of this ball. You can feel the weight of the ball. Means with your therapy sessions, you can modify accordingly. So these few are the technique for any sort of child. Definitely, those who is asking the questions for spastic child, definitely gentle oscillatory movements and in a comfortable manner, not the passive movements. If you give the baby in a comfortable manner, if gentle oscillatory, if you provide gentle oscillatory movements, then if you ask for a active sort of movement or facilitative play, that would be grateful for the particular child or for the particular session. Yeah, thank you.
Thank you. Next question is early intervention differential. Actually, DD, he is asking Upasana how to differentiate CP in early stage.
Okay. Means definitely I am not going with more details of Hammersmith because the time is there is a time constant. If and on that scale, or if you go through the scale, we are trying to more or less cover every sectors. Means we are covering that cranial nerves, we are covering the movements, we are covering the reflexes, we are covering that milestones, behavior, everything. And which was the question, Koshi? Can you please repeat once?
Actually, so you want to know how to differentiation CP and other problems.
Okay. So if I'm telling you that that cerebral palsy and other problem means if you find that means in case of the GM, okay, I'm telling from the GM means very early stage of the life means, and you are want to differentiate cerebral palsy and some other disorders. Means most commonly from other disorders, maybe it is autism, maybe it is learning disabilities, maybe it is intellectual disabilities, may other factors may happen with the kids rather than cerebral palsy. So if we found that in GM also in details assessment or detailed scoring or advanced scoring, if we find that there was that baby is not performing that cramp synchronized pattern of movement, but there is typical rolling type of movements, there is lack of variability, and the baby is doing the activity monotonously. We are not found the cramp synchronized movement, it's an on and off movement, that is a tonic pattern, but the baby is doing a same pattern of movement monotonously. Then we can assume the baby have an issue of learning disabilities or maybe issue of ASD or somewhat else. And if we find that the baby was motorly, the baby was developing according to the age, according to the achieving, according to the milestone, but the baby is not communicating, not eye contacting you properly, not responding, means that the motor development was more or less normal, but the baby was not responding accordingly, then you can smell for some other means others disorders also like autism, like means the babies have a difficulties of communications with others, others family members. The baby has an issue of communications with others peer groups. baby is not able to socialize with others, means the baby is 1 year old but not eye contacting, moving, roaming around. Uh, so that on that time you can smell that the baby has a different issue rather than cerebral palsy. Yeah.
Okay. Next question. In case of spastic hemiplegia CP, how to release fisting movement?
Okay. In case of spastic hemiplegic cerebral palsy, definitely that we need to put the baby in RIP positions. When you put on try to maintain the RIP positions, after that, if you facilitate that particular limbs or and if you encourage for a normal activity, then the fisting will gradually goes on off. Okay, next.
Next, how to manage spasticity of lower limb in CP child of 5 to 6 years? Is there any scope of physiotherapy optic neuritis in CP child?
Okay. 5 to 6 year of child along with adductor catch, okay, or more adductor tightness, definitely a physiotherapist must try about the find out that level, GMFCS level, and try to find out that maximum ability. If the baby or that child, 5 years old child, is that optimize that particular goal, so definitely we stick on physiotherapy more and more. If we are not uh, means achieving that particular target or particular goal, but definitely on that time we do consult from other interventions also. Maybe there was a purpose for botulinum injections, or some other interventions, or maybe some we can take opinion from other orthopedic surgeons also. And optic nerve injury, definitely cerebral palsy, there was many others associated disorders is also present, like visual pathway disorders. In optic pathway disorders, and we do some visual stimulations and very early stage of the life, and there, and I am telling you as CP, it is a umbrella terminology, and many of the professional is working together. So here the vision therapist is playing a major role to take after this sort of things. Yeah, thank you.
Last question of the day.
Yeah, thank you.
How to improve oromotor control?
Okay, this is out of track questions also, but I am trying to give a basic answer of it. But definitely, it is a question for speech therapist. Those are the expert. Uh, uh, you can ask uh, that mother, that the feeding habits, that feeding quantity, feeding time, and which type of food the baby is preferred, and if there is a history of choking or not, if that and you can give gentle stimulations over the lips, you can that's all you can perform with your limits. But definitely it is not your job, it is a job for a speech language pathologist. I think we may discuss this later with some others fellow professionals, those who can describe this betterly. Yeah, thank you.
Yeah, thank you. Now I would like to call our secretary Arindam Seth. Arindam da, please sum up.
Thank you very much, Arafat sir, for your nice presentation. Hope this webinar give lots of input to the participants and the viewers. I extended my thanks to IAPCEC for their continuous support, and I extend my thanks to the IAP technical team for their wonderful job. I extend my thanks to Shriti Pragyan Madam is present for our webinar. And I thanks to the Dr. Kaushik Malik. He's took all the responsibilities to carry out the webinar. And I thanks to whole IAPA West Bengal team and our beloved president and IAP Women Cell for their good work. Thank you. Thank you very much, Arafat sir, once again.
Thank you very much, Orindam, and thank you, Kaushik. Hope IIP will do lots of educational activity in coming future, and all the best wishes to all. Thank you very much.
Thank you, Arafat. Thank you. Thank you, Arindam.
Thanks.
Jaspreet ma'am, up to you.
Thank you so much, sir, for such wonderful and informative session. And thank you, Kaushik Malik, sir, and Subendu, sir, Rishi, sir, Ajit, sir, Arindam, sir, Tanushri, ma'am, for organizing such wonderful webinars. And thank you, whole West Bengal team. I extended my thanks to Dr. Sanjeev Jha, sir, and Ruchi, ma'am, for providing this platform. And I request to all the participants, please like and subscribe IAP India YouTube channel for watching all online webinars. Thank you, sir.
Thank you, ma'am.
And good night, everyone.
Have a good night. Good night.
Thank you very much. Good night. Is it over?